Good morning, tribe. We're here with Debbie with the ECMO specialist. So we're going to interview her today and get to learn all there is to know about ECMO in our short period with her. Make sure you save your questions till the very end. We'll go through the questions that you guys submitted previously. And at the end, if she still has some time, we'll go ahead and answer those. And if she doesn't have time, we can answer those later. Just go ahead and leave them in the comments. All right, so we have Debbie live with us. Hi, Debbie.
Hi, guys.
Let's see. How long have you been in ECMO currently?
So I became an ECMO nurse in 2007, so that was about 11 years ago. And then I got my master's degree in nursing education. And so I became the ECMO educator here at Children's Mercy in Kansas City in 2011. And then ECMO became its own department in 2014, and that's when I became director. So we're right at 4 years this May.
That's great. What did you do prior, and how did it prepare you for a position as the ECMO director?
So I was a PICU nurse for, about 7 years before I became an ECMO nurse. So at our hospital, you have to have been a critical care nurse for 2 to 3 years before applying to the team. And I always like to say I got lucky because I was still on night shift. And so the experience level was a little bit lower, whereas on day shift, it was pretty competitive to get on the team. Mm-hmm. So I luckily got on the team. And then after several years, like I said, I went and got my master's and became the educator. And then when ECMO became its own department, my boss didn't want to be the director of the department. And so they also interviewed nationally. And I was lucky enough to get the position.
Wow, that's great. Congratulations on that. Let's see. So you already answered the question, is this a good place for a new grad to start? You said that your program requires 2 to 3 years. Is that what you said?
Mm-hmm. And I would assume most programs do the same. So we, for our education course, follow the ELSO guidelines, so Extracorporeal Life Support Organization guidelines for education. And so I would say most programs probably follow those guidelines as well, and would choose candidates on the team based off that. Now, depending on where you are, sometimes it's not nurses who sit the pump or ECMO specialist. Sometimes it's respiratory therapist, and sometimes it's perfusionist, depending on how big your program is. Sorry, hopefully you guys didn't hear that ding. My computer's probably going to ding. So if you're a smaller program, you can probably get away with it being a perfusionist-based program because you don't have that many runs a year. But when you start getting into the levels of our program where we have 60 runs a year, you have to start thinking about different ways to run the pump. We've always been, so for many years, perfusion primed the pumps and put the patients on. But when we began in 1987, it was a nursing program. So nurses have always set the pumps or been our ECMO specialists. Mm-hmm. We are actually now bringing some respiratory therapists onto our team as well. So again, you have to have clinical experience. We usually say 2 to 3 years. You can come from another center with experience, but we like you to be in our hospital for at least 6 months before applying to the program.
Okay.
We hire about once a year. I don't know how other centers do it. Well, it's one of those things that once you get on the team, people pretty much stay on the team unless they're going on and getting higher degrees and graduating and going somewhere else. So my advice to a new grad would be if you're interested in ECMO, that you have to pursue critical care, whether that here we do need to feel ECMO, we do pediatric ECMO, so that'll we can make you pick you. But if you're interested in adults, then to critical care unit, then you can go ECMO and start there.
Okay, good advice. So what are the characteristics that make a nurse successful in your area?
You have, it's critical, saying you have to have critical thinking skills is kind of vague, but the definite, you have to have that, and most critical care nurses, possess that. Flexible with change. So ECMO is not what it was 5 years ago even. It's just a rapidly changing program. So when anybody interviews onto the team, I always have an example of a time dealt with change, because we are constantly changing how we staff. The patients that we're taking care of are constantly changing. So I always tell them our goal is to be able to take care of any patient that walks into our hospital, no matter what size why they're going on ECMO, those types of things. So flexibility would change. Just being able to go with the flow. Being open to learning. I always tell when people come through the ECMO course, I always say, I've been sitting through this ECMO course for the last 7-8 years, and I learn something new every time. So just, being a lifelong learner.
Yes. It's super important in our profession as a whole, but definitely in a elaborately changing industry like ECMO. Let's see. What do you love most about ECMO?
Oh my goodness. I think that's changed over the past several years. I used to really like the critical nature of it, and just, really being the highest level of life support. Now, like with our ambulating patient, it's brought something different. It's, I don't really know how to explain it. So we used to not interact with our patients because they were sedated and paralyzed. And so it seemed so critical. And not that now with them awake and texting their friends, it's not as critical. Sometimes I think people who are walking by don't really realize what we're doing. But it's just a whole different level of care. I love that it keeps expanding the type of patients we could put on. Like, for instance, cancer patients used to be an absolute no. Like, we would just wouldn't put you on. Whereas now, if you are going through an acute process like pneumonia or something, your cancer doesn't not make you a candidate. I love it when people come back, either if it's a newborn baby that we had to put on. I think that's such a difficult time as a mom when you have this baby and they're ripped out of their arms and taken to ECMO. And typically those are our shorter runs. And it's nice. They send us pictures every single year of them growing up, graduating from high school. That's lovely. And then on the pediatric side, the kids that were previously healthy and then all of a sudden end up on ECMO, but then they get to go back to their life and they're fine. I think it's amazing to see.
Yeah. And what's the hardest part of ECMO?
The ones that don't end well, I would say. And it's a hard concept when they look alive because you're providing all the work of their heart and lungs. And so I think that sometimes that's really hard for parents to understand that we can't do anything more. We always tell parents that ECMO is not a cure. It's not fixing anything. It's just giving their body time to heal. And so their body has to heal. And if not, then, support has to be removed. So I think that's probably the hardest one.
We just received a comment that the audio is echoing off and on. Unfortunately, I think that's due to the internet connection. So I apologize for that. Just bear with us and hopefully maybe the replay will be a little smoother. Would
it help if I maybe turned my sound down? Let's try that.
I can hear you really well, guys. Let us know if that helps anything with the audio.
I can hear a little bit of an echo when I talk too. So.
Oh, okay. All right. Sounds good. Okay. So let's see. We got some pretty broad questions and some pretty specific questions from the tribe. So I guess we'll start with our broadest question in that, what is ECMO?
Okay. Maybe we should have started with that one. So ECMO stands for extracorporeal membrane oxygenation. So it's where we take the blood outside of the body and we perform the work of either both the heart and lungs or just the heart or just the lungs. So there's two different kinds. There's veno-arterial. So we drain the blood from a vein and return via an artery. So you have to be on that mode if you need heart support. Or there's veno-venous, where we drain from a vein and return to a vein. And in that one, your heart has to do the work to pump the blood out to the rest of your body. So typically, for my kids, you will see a neck cannulation. So the cannulas go, the venous cannula goes in your your internal jugular down into your right atrium, and that drains the blood out. And then if you're on VA, you have then a cannula in your common carotid, which goes straight to your aorta. So you're completely bypassing the heart. So when we talk full flow, it means very little blood flow is going through your heart. We're doing all the work on the machine. If you're on veno-venous, then there's two different types of cannulas. typically it's a double lumen that goes right into your right atrium. So you're pulling from the right atrium and returning to your right atrium. So again, your heart has to pump then to get the blood to the rest of your organs, whereas in VA, that's not happening. You could see chest cannulas. So if we have a patient coming out from bypass surgery, so those are a lot of our kids, either their heart isn't happy because you cut on the ventricle or they have some sort of heart failure. They will have cannulas directly into their chest. So the same cannulas that they use during bypass surgery, we will just then convert over to our ECMO system. Big people, you will see sometimes groin cannulations as well. So you have to have a cannula somewhere in a vein or an artery, depending on what mode. It comes down to our system where we have a pump that keeps the pump or the blood going forward. And then we have something called a membrane oxygenator. I don't know if you can see my hands. It's the lung of the pump. So it does all of our oxygenation and ventilation for us. And then it returns to the patient. We also have the ability to do dialysis on our machine as well if your kidneys happen to not be working as well. So it's really just allowing your heart and lungs to rest. In the neonates, we see meconium aspirations, we see congenital diaphragmatic hernias, primary pulmonary hypertension, sepsis. In our big kids, it's across the gamut. Most of our cardiac kids are those failure to wean from bypass, post-cardiotomy. We have a lot of myocarditis that we put on. And then on the general side, we have all sorts of pneumonias, flu, RSV. We've had aspirations that we've put on, ARDS, you name it. Ingestions. So either unintentional or intentional. So sometimes it takes a while for us to clear it. And so if they're in a lethal arrhythmia or whatever, we can support them through that. I think that's a weird concept for new grads to get to. They'll walk by an ECMO room and they'll say, patient has no heart rate. And we have to remind them that's why they're on the pump. Like you can have no heart rate and still be living. And that's why they're on. And then hopefully that heart rate will be back. Does that explain what ECMO is?
What's that?
Does that explain what ECMO is?
Yeah, for me, we'll take more questions as we get through. Did anybody have any specific questions about what ECMO is specifically? I don't see any specific questions. I see a comment. My ECMO experience is 60-40. 60% of them die and 40% of them live. I also believe the longer they are on ECMO, the worse their prognosis is. Do you want to speak on that, Debbie?
I would say we're a little bit higher than 60-40. Our survival to discharge is right around 70%. Again, I think it really depends on what you're going on for. So if you're talking about a neonate who just has meconium aspiration, they have a 99% chance of survival with it. And again, those are typically shorter runs. Mm-hmm. Obviously, if you are in multi-system organ failure before you go on, your chances are pretty slim. Cardiac ECMO, again, depending on what you go on for, but the congenital anomalies, they have a lower survival rate. If you go on coding, so we're doing compressions while we're putting you on, your survival rate's about 30%. Mm-hmm. But as a parent, I would tell you I would take that 30% over certain death right at the time. And a lot of the times when we're coding and going on to, I often tell my team, because we get the why did we do this? That we had been coding for 30 minutes. I always say, it gives the family a little bit of time. It gives us time to figure out why they coded. Sure. There's anything that we can do, so family really feels like we did everything. What was the other part of that question?
That was about it. She just said that the longer that you're on ECMO, the worse your prognosis is.
Definitely, depending on what you go on for. I think a lot of you have heard of our patient that made national news who was on for about 6 months, and because she was walking and not getting deconditioned, she really, the longer you're on hasn't been a complication for her. Certainly, the longer you're on, the more complications you can have. I always tell families it's just a machine. It can stop at any time. Blood clots, we have to keep the blood thin. So it's a constant balance between them not bleeding and our pump not clotting. So the longer you're on, the more component changes you have. So definitely we like to get them off as quickly as possible. but also with the patient who has like ARDS, there's really not a lot of literature out there that says how long it takes for the lungs to recover. And so there's a lot of people in Sweden who are on for 6 months plus and survive to go back to work, adults who survive to go back to work and not have any disability.
Pretty incredible. I think this leads in well to one of the questions. Are the walking ECMO patients using a different circuit?
They're not, and that's actually kind of part of our story. We knew that other centers were ambulating, and we learned from those centers it was mainly adults. Duke has done a lot of adolescents who were awaiting lung transplant. So again, if you were on ECMO, it used to be a contraindication to get a lung transplant because you were so deconditioned. But they started putting their kids on ECMO and ambulating them, and then they were actually really good candidates for lung transplant. So that was kind of my first exposure, and that's been several years ago, 5-6 years ago, to, oh gosh, we can do this in our population too. It's not just the adults. So we would see these smaller circuits. Our circuit is literally just, we took a bypass circuit, a cardiac bypass circuit, and we made it ECMO. So it's very big and large and hard to push. Now, once we got, we started doing more VV ECMO. So typically when you see patients up and ambulating, most of the time it's VV. So a vein to vein, not vein to artery, although there are some centers doing VA as well. So once we started
ambulating on VA?
Yes.
Okay.
Yeah. Once we got a different cannula to do VV with, it's a little bit more secure. Mm-hmm. We knew we were possibly going to be ambulating. And so we were working up to getting a smaller footprint for our pump. Across the country, a lot of people are using something called the CardioHelp, which is a really nice compact pump. A lot of adult centers use it. We have not, it's not great for little bitty kids at this point. So we were working towards that. And our goal for the end of 2017 was just to sit somebody up on the side of the bed. But we had a patient who was really determined, and her mom is a nurse as well, and was looking things up, saying, hey, the center's doing that. And I remember sitting the mom down and saying, we will do as aggressive PTOT as we can, but we are not ready to ambulate. Our circuit is just too big. Mm-hmm. And then my boss actually said to me, well, you take it to CT. Why can't we walk with it? So we did. And so when anybody sees the videos or whatever, they're like, oh my gosh, your circuit is so big. Why don't you have the CardioHelp, or why don't you have a smaller pump? It really was just because we didn't have time. Like all of a sudden we'd been planning for it, but all of a sudden we had a patient who was ready to ambulate, and we just made it happen. And we're still not ready to convert to the CardioHelp, but we do have now the smaller footprint. So hopefully our next patient, it won't be as big and bulky. Mm-hmm. But again, there's a fiscal responsibility there too of how many of our patients are going to be ambulating and how many do we need to buy and those kinds of things. Sure. So we definitely do not have a different circuit.
Okay. Let's see. How do they account for the increased metabolic demand and flow while the ECMO patient is ambulating?
Yeah, so that's interesting. I had gone up to Michigan and shadowed, and they sometimes will throw 2 oxygenators in for either because they need better CO2 removal or just for ambulating. They know about that increased metabolic demand. We didn't really experience that so much. And again, we kind of let her drive our process. And so there were times where we were walking where her stats were pretty low and we were getting nervous, but she was fine. And so we didn't really do anything. We would usually walk her on 100% oxygen, kind of support her as much as we could on the pump. So you would see that when she was asleep, she would require less support than when she was awake, or when she was having a coughing fit, or when she was ambulating. And so we would just support her accordingly, adjust our gases and our flow and all those things to help that.
Great. Let's see. Someone said, what are the benefits for ambulating patients on ECMO?
So I kind of already spoke to what you kind of saw. And at the beginning of that patient's course that was in the news, that was our goal, was to make sure she was still going to be a lung transplant candidate. And she ended up, getting to a point where we didn't think we needed lung transplant anymore. But adults especially, they get contractures so quickly, like within 12 to 24 hours, you start fractures. So we just don't want them to muscle waste and extend their ICU and or hospital stay because they've been lying in a bed for weeks or months. And we also found that her chest x-rays got better when we would get up every day. So I think it's got a lot of benefits. And that her mom will speak to kind of the mental or psychology kind of piece of it, because there were days and weeks and months where we were not seeing a lot of progress in her lungs, but she thought she was getting better because she was able to do things. So, normalcy, getting up in the morning and putting regular clothes on, having a plan for the day, doing schoolwork, like all these things when you're sitting in ICU are just really helpful for that side of it.
Sure, that makes a lot of sense. So what are the barriers to adding ECMO to a hospital, and specifically a hospital that does open heart surgeries? So the person that asked this question elaborated a little bit more. She said that her institution does open heart surgeries and obviously bypass, but they are not equipped to do ECMO. What do you think the barriers to that is?
I probably need a little bit more on whether they're a pediatric or an adult center. Here in Kansas City, we're the only children's hospital. We have several adult hospitals, but only 2 of our hospitals do ECMO. So there's kind of 2 different schools of thought on ECMO, that maybe every hospital shouldn't do it because it's still a specialty. And if you only have 1 or 2 runs a year, you're not going to be able to stay competent. And so there's a lot of debate about that in the ELSO community about should centers that do less than 5 runs of ECMO a year do ECMO? Should you just not get them to an ECMO center? So there are lots of hospitals out there that do bypass surgery but do not have an ECMO program. So I think you would just have to look at what are the chances. I don't know if they've seen the need, if they've had patients they've had to transfer out for ECMO. So I think I would look at those factors first before making a decision whether or not they would need ECMO at their program. And also, it would probably start with just the perfusion group. So you have to have a perfusionist to do bypass. So they could work to convert the equipment to be ECMO and get what they need. And then it's just about the training and the education, which, up front is a big ordeal fiscally, and then also to get everybody up to speed. Right.
And then the last one, actually, I have a question that kind of relates to the ambulation that someone mentioned to me. Do you think a big barrier to ambulating some patients on an ECMO would be staffing? These smaller institutions that do have ECMO programs, but yet don't have a whole army of staff to come walk this patient. Is that a big barrier to that first step in ambulating?
Definitely. It does take an army every day. And so I often reflect that when we were a perfusion-based program, I don't know that it would have been able to happen because the perfusionist really belong over in the operating room, or at least that's how it's set up at our hospital. So it depends on how many perfusionists you have, but we have an ECMO core team. So it's kind of 2 separate groups. So we have our ECMO specialists who are nurses in the NICU and PICU who are trained to sit the pump. And then we have core team who are free. So they're kind of like our firemen. So they're available to put patients on, troubleshoot or whatever. And so we knew every day that our patient was ambulating at 2:00. And so the whole army showed up. That included the ECMO core team member, the specialist at the bedside, her bedside nurse, physical therapy, respiratory therapy. The doctor had to know every time she got up. And so it does take a lot, and it's a big commitment. And we do a lot of simulation here. So we had a mock ECMO simulation the other day where someone was coding, and as they were getting ready to do it, I was like, oh, but we're getting ready to walk on ECMO. They were like, that could really happen. And I'm like, you're right. So we should probably sim it. So, I blinded my team, and we were in the middle of the walk, and the pager goes off, and they had to figure it out. But it does take a lot. And so you have to have the resources. And that was another reason why we were able to develop it so quickly. I mean, we've been working on it, but it's such a multidisciplinary approach, and everybody has to have buy-in. And then initially when we started talking about this, 5 years ago, when I'd bring back videos from conferences, like, look what these people are doing, this is crazy, I did not have the buy-in. And so we had a multidisciplinary team get together, and they kind of came up with the safety checklist and all those things of like, this is what we need to do to feel safe and be successful. And so it kind of gave them ownership of the process.
That's amazing. And then the last scheduled question was, how much does it cost a day to run ECMO?
So that's a loaded question. And again, it depends on what equipment that you have. And so when we put a patient on, they get charged initially for that disposable. And then about 4 hours of professional time to actually put them on. And then they're charged every hour that they're on ECMO. And they're charged, if we have to do any component changes, again, they're charged for that equipment and that professional time. So you're mainly paying for the professional time. They're already in the ICU, so they're already getting the ICU bill, the bed charge, and all those kinds of things. So I believe right now what we charge, it doesn't mean we get reimbursed for it because we have insurance and all those things. I believe we charge about $600 an hour at this point for our services.
And that probably depends on institutions as well.
It really does, yeah. And who's sitting your pump, because you're really paying that specialist kind of professional time. Once the equipment fees and all those are taken into account.
Okay. Here's one of our extra questions from one of our viewers. Let's see, an extra question. Can you prone an ECMO patient, like with an intubated ARDS patient? I work exclusively with adults, by the way.
You can. We have not done it here. I know Michigan has done it. I had one of my employees went to a conference up there, and they're like, they're proning their ECMO patients, by the way. Again, I think it just depends on what school of thought you believe in. I think most of our intensivists here don't believe prone positioning helps. And so most of the time, if we're getting to the point of proning an ARDS patient or anybody, we're thinking we probably need ECMO. But we have not proned the ECMO patient. Now, I did walk into, again, our patient that made national news with walking PT-OT session where they were having her kind of lay on her stomach and do some, what are those called, planks?
Yeah.
I was like, whoa, what's happening in here? Because we always have to worry about the position of the cannula, like safe position. So I was like, maybe we shouldn't do that. But they were, and we were always kind of pushing the limits with her. And if PT-OT thought she was ready to do something like an exercise on a balance ball or whatever, we just made sure she was safe and that we could do it safely. So.
And was that a helmet that she was wearing that attached her cannulas?
She did not have a helmet. I did see that. So I saw someone comment on it in Denver. They did use it one time. I think it was I think he was 5 years old. I can't remember. They did adapt a ski helmet to put the cannulas to. We did not do that. Because again, when she's laying in bed, she can't have the helmet on. So she had a modified, so I'm trying to think of what you guys would use them for. So like a Foley, some places use like a Foley strap, like you use a leg bag too. Hers was a low perfusion sat probe cover. So it's just like a little Velcro, very like a Foley strap. And so she always has one on her head when she's laying in bed. And then when she would get up, we would drape them over and put a net. So she had headband securing here. We would drape over, do another headband here, and then have the cannulas come in here and pin it to her shirt so that if she went somewhere, the cannulas go with her.
Interesting. Okay.
And we did cut in length to do that too. So you have to have enough, room to walk as well.
Right. And then someone made a comment, Hantavirus. I'm assuming, in New Mexico, we put people on ECMO for Hantavirus. I'm not sure if that was a question or more just a comment.
I have no idea what that virus is.
Okay. No worries. Here in New Mexico, we're
it's very
popular. It's a virus contracted from mice. And it's nasty, and it's contracted from the feces. And so, like if they're in your storage unit or something, you can get it from them.
I think I've seen that case presentation at a conference on that. Yeah.
They actually have a decent survival rate if you get them on pretty quickly. And we here in New Mexico, we have never, actually, no, that's not true. They ambulated their first ECMO patient here recently. But prior to that, we were sedating and paralyzing for quite a while after that initial Duke study, but things are loosening up and people are getting more comfortable, which is phenomenal for everyone.
Well, that's it too. Like, again, with putting that story out there, we got a lot of, we've been ambulating for a long time. And I'm like, I know, but there's still a lot of centers out there that haven't. And right. I think if there's one hospital that's solid and we're like, hey, we can do that, or learn something from her story, I think that's great. The one thing we do that is unique is we do extubate our patients. We don't trach them. Mm-hmm. So most hospitals like to have a secure airway. One of our physicians here really believes that it doesn't really matter because their lungs aren't great anyway. So you can bag through whatever. It's not going to make a difference. And so she chooses to extubate so people don't increase the ventilator settings. And, because most of the time any sort of pressure is going to blow a pneumothorax or something like that. So there's something else that you said. Go back to the mice virus. Did it just attack their lungs or did I get like septic? Like, did they go on BA or did they go on BV?
I'm in peds, and Hantavirus it's typically only in adults. I've never seen a pediatric Hantavirus. Anybody listening, can you speak to that? Anybody listening can speak to it? I'm pretty sure it's just VV, but anybody have expertise in that wants to share? Destroys the lungs. That's what I thought.
Okay. So you could be VV, yeah.
Yeah. So another question, have you seen a lecture from Dr. Lemieux, French, who heads up ECMO in Paris? They put people on ECMO in the field.
Yes, I have seen that lecture, and I have seen those pictures of them putting someone on in the Louvre. Just kind of crazy. So I think that's where we're going to get in the United States as well. I don't know how far we are away from that, but the equipment is getting smaller and smaller. And if you have somebody skilled enough to go out in cannula, I think it's great. My previous chief perfusionist here, who was Gary Grist, he was amazing, and he's kind of well known in the perfusion world. He told me before he retired, he was like, I think we're going to get to the point where you won't die unless you go on a pump first, especially if it's like cardiac arrest, so kind of like an AED out in the field, which would be phenomenal.
Yeah. I actually saw that months and months ago. I had forgotten about it. It was pretty interesting. Last question that I see here, more of a comment. It's an incredible program with an interesting tiered response EMS system that sent an MD and nurse in their ICU ambulance to put qualifying patient on ECMO wherever they were. Yeah. It's pretty cool.
Yeah, I think Germany is doing it too.
Oh, really? That's interesting. UNMH, that's here in New Mexico, is starting a selectively extubated ECMO program. So awesome. We're all making super big changes. And is there anything big that you would say in your institution changed for the one patient that you guys have ambulated on ECMO? Is there anything that your program as a whole is doing to take those steps? You said the footprint for your machine, you're hoping to get a smaller footprint. Anything else other than that we as nurses can advocate for our ECMO patients?
One thing that we did start here a couple years ago was we have if you already have an ECMO program, we have a shared governance committee called the Clinical Practice Committee. And so it pretty much is run by the specialists themselves. Now, I will go if they ask me to go. Our educator is the one who heads the program or heads the committee. We will have perfusion come as liaison. Sometimes they'll ask docs to come, but they really own their own practice. And so if they are upset about something or if they want to make a change, it goes to that committee first and then recommendations come out. And so that's, again, kind of what we did. I knew we were going to get to the ambulation piece, that we were just waiting kind of on our candidate. And so I took them all the resources that I had from conferences and centers that, I have colleagues at, but I really gave that to them and said, you guys need to figure this out because you're going to be the ones doing it. And what do you need? And so I think that's kind of the key message, is that if you let them own their practice, they'll do great things. We are huge on checklists here, safety checklists. And so, and we're more than willing to share the checklist we came up. So we have one for sitting up in the bed and standing for the first time. And then once they actually go to ambulating, then we personalize it to them, because it depends on what equipment they have. Do they have a high flow nasal cannula? Are they still on IVs? Those kinds of things. So safety, and make sure you have a lot of buy-in. but I think it's opened so many minds. Even in the NICU where they don't extubate or whatever, like people are starting to talk about it. Like, well, why couldn't we extubate a neonate and let them suck on a pacifier? Some of those kind of things. And so I think it's just opened people's minds that ECMO isn't what it was, 20 years ago, definitely, but not even what it was 5 years ago.
Yeah. Big changes. It's so exciting. Well, thank you, Debbie, for all your expertise. I don't see any more questions coming through at the moment, but would you be willing to answer some more questions if they come through when people watch the replay?
Absolutely. If they just want to comment, and then I'll try to go in and answer them the best that I can.
Awesome. Sounds great. Thank you so much for your time, Debbie. I appreciate it.
Have a good day.
Have a great day. Bye.